Welcome to Physician Focus. I'm Dr. Bruce Karlin. Emergency medical care has become a key part of our healthcare system, with an estimated 1 of every 5 Americans visiting a hospital emergency department every year, for a total of nearly 130 million visits annually. Hospital emergency departments manage more than 10% of outpatient hospital visits, handling a wide range of medical challenges, often under difficult circumstances, yet they are staffed by only 4% of the nation's physicians. This edition of Physician Focus takes an inside look at the emergency department and how it operates. We'll discuss the priorities medical personnel use when patients present themselves, the role of the emergency department in today's healthcare system, what patients should consider and expect when thinking about visiting an emergency department. With me for this discussion are Doctors Nathan MacDonald and Jeffrey Hopkins, both board-certified physicians in emergency medicine, and both are fellows of the American College of Emergency Physicians. Dr. MacDonald is Chief of Emergency Medicine at Lowell General Hospital in Lowell, Massachusetts, and President of the Massachusetts College of Emergency Physicians, the statewide specialty organization with 950 members. Dr. Hopkins is Chief of Emergency Medicine at Milford Regional Medical Center in Milford and Treasurer of the Massachusetts College of Emergency Physicians. Welcome, doctors.
Thank you, Bruce.
Thanks for having us, Bruce.
This is a really interesting topic because everybody sees emergency physicians, quote unquote, on TV shows, but we're going to get into the real deal. First off, could you tell us what is your training to be an emergency physician? Nate?
Yeah, thank you. Emergency medicine has been recognized as a separate specialty since 1972, and training includes residency training in emergency medicine with a focus on treating acute cases, of all types of patients. So training really encompasses adult medicine, pediatrics, obstetrics and gynecology, surgery, again with the focus on treating acute illness and injury.
And the front line, the presentation of the illness.
Exactly.
And so the emergency room has become our safety net. And describe a little bit of what you end up seeing in the emergency room.
Sure. We see a variety of things in the emergency department. We see patients of all ages. We see patients who are insured, patients who are uninsured. In fact, most of the time, I'm completely blinded by someone's insurance status, because our mission is to see whoever comes through that door, and they can have conditions that are minor illnesses, they could have major traumas, they could have serious life-threatening conditions. And part of our training is to be able to provide care for whoever comes in that door. And sort of a newer specialty within the past 40 years where they've had dedicated training to allow people to work in emergency departments and be ready to handle whatever comes in through that door.
Nathan, earlier in the discussion we were talking about how the emergency room used to be exactly that, an emergency room. Perhaps you could expand on how that has come to be an emergency department where you're really set to all that emergency triage, all the initial workup of patients is really in your departments.
Yeah. Well, you're exactly right. Back in the day, many hospitals had what was described as an emergency room, and it was literally a room, and there might be a couple of stretchers, there might be a couple of chairs outside the room for patients to wait. It would be staffed by a nurse, perhaps, and there might be a physician there, or there might be a physician elsewhere in the hospital who was called down to see patients as they came in. And before the specialty of emergency medicine, those physicians might have training in other specialties, medicine, surgery, et cetera, and would be moonlighting, as we say, in the emergency room. Today, really, it's a sophisticated department. It's multiple rooms with multiple functions, and really has the capability of doing just as you said, of really taking that patient in, identifying what their illness or their injury is, triaging them to different parts of the emergency department, and then completing all of the complex workup, including blood work, including taking of x-rays, the use of CAT scans or ultrasounds to do the diagnostics. And again, it's staffed now by nurses with specialized training in emergency care, as well as physicians who have that training as well.
You also do emergency interventions as well, so you've got some of the surgical skills, many of which those of us who used to moonlight, would be fearful of doing, but would manage to do. But you guys get special training in that, and it's really become a far more robust discipline.
Yeah, in order to really be able to handle whatever comes through that door, you have to know how to do some of those procedures that in the past maybe just one specialty would sort of be the expert in laceration repair or trauma. But really focusing on resuscitation of patients as they come in, initial stabilization, and then some of the procedures that emergency physicians are trained specifically for are things like airway management. If you need a tube to help you breathe, putting in chest tubes, putting in deep, what we call central lines, or even doing what people call spinal taps. There's a variety of procedures. That's the tip of the iceberg, but it is a very specialized training program to become an emergency physician.
And what I see now with my practice as a primary care physician is that I often depend on the emergency room. I've got a patient with an acute problem that I know is going to need hospitalization, and it's in my role now, I look to call the emergency room, say, so-and-so is coming. Here are the problems, and I'm impressed that if I've missed something, you guys do a full workup, and it's a team to get the patient best handled. A lot of patients don't have primaries that they refer to before they come in, which, in my estimation, is a tragedy. But can you describe what your role is with primaries or without?
Yeah, no, that relationship with the primary care provider as well as with the specialists that we interact with is really a key part of what we do. And we would like to think that we complement each other in terms of what we do. Certainly where the patient has their established relationship with their primary care doctor and gets all their ongoing care there are often instances where an acute problem arises, and the primary care physician needs to send the patient to the emergency department to access that quick diagnostics that we have available. Again, we can do laboratories, we can do x-rays, we can do CAT scans, we can call on other specialists within the hospital to come and evaluate the patient. And then at the end of the workup, the patient may get admitted to the hospital, but oftentimes they'll go home with a treatment plan, and part of what we do in a modern emergency department is communicate that back to the primary care physician so that the patient has a coordinated plan. So, and that's key to the highest functioning emergency departments.
So, what should a patient do to prepare for an emergency? You say prepare for an emergency. They're called emergencies. How can you prepare for it? So, what would you suggest?
Yeah, you never know when an emergency is going to happen, but there are some things that you can do ahead of time that will make it a lot easier for the care that you receive in the emergency department, to make sure that we have all the information. Oftentimes during emergencies, this is a very stressful time. This is maybe the worst day that person has had. So you forget about some things. Sometimes you may not have the list of medications that you're on. You may not have, remember off the top of your head, what allergies do I have? Some people don't remember the name of their primary care doctor or a contact number for a relative. They won't have things like advanced directives. So there are a lot of things that you could do in preparation for an emergency, because you never know what's going to happen. But if you have those things that you can put down and have them in a place at home or in your wallet, so that if you ever do have an emergency, you have that information that you can easily give to your physician. It really helps us coordinate care with your doctor, make sure there aren't any medications that we need to know about, any other prior conditions. And I think that's the best way that you can prepare for an emergency.
What percentage of patients do you know this on when they come in? There's big smiles here. I know what this is coming from. Yeah.
Single digits.
0.1?
Yeah. I think we're single digits.
So what would that do in terms of cutting down emergency times?
I think it would help tremendously. The intake process, oftentimes patients who come to the emergency department will say, geez, I've been asked that question a bunch of times. And you'll have, the nurse will come in. You'll have triage that asks them the question. You'll have if you come in by ambulance, the paramedics have asked that question. And then the physician's asking the question. And then by the end, you don't remember who you told what to. But it would really help to sort of have the most efficient care where everyone is on the same page, and everyone has an up-to-date list. That's the other thing, that people's medications change frequently. So if you have a up-to-date list, then everyone sort of knows what your medications are and knows how to best treat you.
Well, maybe we should reiterate what are the items there.
Yeah, I mean, we spend, and I'll just echo what Jeff said, I mean, we spend sometimes a lot of time just trying to gather this information. So if patients know who their primary care doctor is, and if they have a phone number, great, but oftentimes if we have a name and a location, we can track that person down. If they know what their medical conditions are, if they have high blood pressure or diabetes or heart disease, if they know what their medications are, and this is probably the single most important thing you can carry with you. Make a list and put it in your wallet or your purse.
And update it.
And update it, because if it's sitting at home in a desk drawer, it doesn't help when you've been in a car accident. So, really that's something that you should have on your person if possible. A list of any medications that you're allergic to. This can be critically important. And then, an emergency contact number, so that we can get in touch with your family or loved one or friends who might need to be notified. Lastly, for patients who have advanced directives, meaning that they've made decisions about types of care that they do or do not want to receive, such as a do not resuscitate order, it's vitally important that you have that information available.
Well, conversely, it's also important to say you want to be resuscitated.
Correct,
too.
right.
That's not bad. But I think that in preparation for emergencies, the things you list are things that we should be doing anyhow.
And
I
it's
think
pretty simple. Yeah.
It's fairly simple, but not, as you say, single digits.
Yeah.
And I think that it's very important that patients do this. This is talk about advanced directives with your primary physician at some point and get that done, because you come in, you don't know when the funny thing is going to happen.
That's right.
And it's real important to have that with you. Right. So what should a patient expect when they get to the hospital? Let's pretend that they don't have all their their lists with them.
Well, and it can be a frightening experience, and it's certainly not the way that most patients plan to spend their day. And it can be frightening. It can be a little intimidating. But I think the best way to describe what happens in the emergency department is an orchestrated chaos. So when a patient walks in, there may seem to be a lot going on. A lot of other patients are being evaluated. There may be a lot of staff engaged in various tasks, but I think the most important thing is to remember that those people are doing what they're doing for a reason, and they're doing it to deliver the best care to all of the patients that are in the emergency department. So when you walk in, if you come in to the waiting room of an emergency department, you're typically greeted by somebody at the front desk, and typically they'll get just very brief information about why you're there, what's your chief complaint, and perhaps some very basic demographic information like a name or date of birth. And then typically we'll see a nurse, and this might be a triage nurse who has a room right up front in the waiting room, where they will get some more information about medical history, medications, again, vitally important, allergies. They'll take vital signs, they'll take your blood pressure, they'll check your heart rate, check your oxygenation and your temperature. And then based on that initial evaluation, you may go directly back to a treatment room, and part of that triage process is really identifying those patients who need the most urgent intervention. Some patients may still have an urgent problem, but they can get some diagnostics started. They can get lab work started, or x-rays, or get things going, and then those patients may be evaluated in a more stepwise fashion. And then you'll come back to a treatment room.
But my sense, and what I see in our emergency room all the time, is that triage process happens quickly, and somebody is aware of the urgency of your problem and knows to jump the queue if needs be, and that, you know, so once you've made it by the initial barrier, you should feel pretty comfortable. All right, it may take a while.
That's right. Yeah.
But I'm okay.
So once you've gone through that triage process, we sort of arrange patients according to how sick they are. So the sickest patients will come back first. I've had patients ask me before, you know, I came in before the patient behind me, and I'm not quite sure why I waited until that other patient went in front of me. And oftentimes it's not things that are obvious. You know, you don't see a big deformity of a, you know, dislocated shoulder or something, but it could be something like chest pain, which is a very serious condition that you need to get back and you need to evaluate in a more time-sensitive manner. And we try and get to see those patients as soon as possible as well. So when they come back into the department, that's the patient who has the highest urgency or highest acuity. That's the patient that we go in to see first.
So indeed, some of those things that seem to be more needing of care, a laceration, for example, it can wait for a little bit. For the chest pain, which the guy looks perfectly comfortable in where he is, but you know that there's those still waters run deep.
Yeah, there's a higher chance of a serious complication with that person having chest pain than a laceration. Although, you know, people see blood and say, geez, that seems pretty serious, and it can be, but again, we try and differentiate the life-threatening things from the more minor things that we can, you can take a little bit extra time.
Right. The other thing you'll sometimes see in an emergency department are different tracks. So the more minor complaints, such as ankle injuries or lacerations or things of that nature, may go to a separate part of the emergency department, and we do that so that we can really try to keep all of those patients moving in the direction that they need to move. And so patients may get confused when they're being sent to different parts of the emergency department, but often there's an acute area where the heart attacks and the other really life-threatening problems are taken care of, and there may be a fast track or a minor treatment area where some of the other things are handled.
I will point out, you guys have been trained at separating these things out, and you should trust that you're doing it. And you're also measuring how quickly you move people through. That's one of the metrics I know that the American College of Emergency Physicians focuses on. Says, we want to provide good, prompt care.
Yeah, absolutely. We want to keep all of those patients moving again in the direction that they need to be going in. So.
That's right.
So, when and how should we go to the emergency room? Should, I've got a little cough, I haven't seen my primary in 3 weeks, or 3 years, excuse me, and it's a Saturday morning.
Sure.
How do we make these, what are the warning signs that say, geez, I better get there?
These can be tough decisions. I mean, there are certainly some very serious warning signs that you want to be aware of. Anybody who experiences chest pain or difficulty breathing, anybody who has any signs of a stroke, such as a weakness in a portion of the body or slurred speech, anybody who has a severe headache, anybody who has severe bleeding, is vomiting blood, you know, there are certainly some things that we want people to not fool around with, and just, you know, get straight to an emergency department or call an ambulance.
I'll bring that back as a primary care.
Yeah.
There are a lot of these that we see in our office all the time, and I would make a pitch for saying, if you've had 3 weeks of chest pain, just because it's Saturday morning doesn't mean that you need to call about it. But when you're having those symptoms, by all means, call your primary. And oftentimes, the primary will say, wait a second, don't fool around with that today. And that gets back to our partnership as to how we deal with that.
Absolutely.
But there are some warning signs that obviously don't mess around with.
Absolutely.
So if some body part begins to fail to function, that would be one. Chest pain like you've never had it before, that would be another one. Obviously, blood spurting from places that it hadn't been before is worthy of note. Do you have another couple that you can add to that?
I think the other one is just if people feel that they have a true emergency, they don't think that this is something that can wait, then I would advise that patient to come to the emergency department. Now, if you have time to call your primary care doctor and you think this is maybe more of a routine thing, then you can try and call your primary care doc. But it's difficult for patients to triage themselves, and really that's what that's our specialty. All of us here, we've been trained to sort of figure out the sick from the not quite as sick, and what is emergent and non-urgent. But it's very difficult for patients, I think, to
triage themselves.
Yeah, to triage themselves.
But you've got help. There are other places that you can get help. You can call your primary if you've got time.
Yeah.
And what about some of these other lesser items? Let's say the off-hours clinics that we've got.
So there are retail clinics and there are urgent care centers, and they've been popping up and more frequently recently. And the main difference between either a retail clinic and urgent care center versus a emergency department is really the resources that are there. There are different staffing patterns depending on which facility it is, but a hospital-based emergency department has the facilities that you would need to treat just about anything. Now, there are different levels. There are tertiary care centers where they can take care of just about anything, and there's community hospitals which don't have necessarily every specialty, but the emergency departments at a hospital-based emergency department has all the resources in terms of the testing that could be needed, imaging that could be needed, lab work, respiratory therapy, IV therapy, a lot of the things that some of the retail clinics don't provide. And again, it varies based on which retail clinic or which urgent care center. But the other thing is that the emergency department is open 24/7, 365. It is a place that never closes. So depending on which place you go, they could have hours that are, they stop seeing patients at, say, 8 o'clock at night. The emergency department, you can rest assured, we never close.
And you take everybody.
And we take everyone who comes to our door is seen regardless of ability to pay, and has a medical screening exam. And if an emergency condition is present, then we treat that emergency condition.
I think it's important to note, however, that patients should be aware of which emergency room they want to go to. With today's insurance world, it's very important to know the proper place. And
I think that's a good thing to identify early on, especially when you're on your at home, from your home. Where would you go to an emergency department? And that's a good conversation to have with your primary care physician, because they may have a hospital that they're affiliated with and would prefer you to go to that emergency department. Of course, if you're away from home or in unfamiliar territory, you have to go to the closest emergency department. But I think that's a perfect part of the plan, is to know where you're going to go, how you're going to get there, if it's by car, of course, if you have any serious signs, you want to call an ambulance, but have that discussion with your primary care doctor.
Believe it or not, we're coming close to the end of our time here, and I'm wondering if you each have some important thoughts to leave the audience with. Jeff, why don't you start?
Sure, yeah. I mean, I would tell the audience that emergency medicine has come a long way. 40 years ago it was a different specialty, and we talked about the emergency room. Today, emergency physicians are board certified. There is a specialty training, and there are emergency departments that have the ability to take care of whatever comes in through that door. That's what our training allows us to do. So again, being open 24/7, 365. We are always there to help. If you feel that you have an emergency, come and see us anytime.
Nathan?
Be prepared for an emergency. So just as we talked about, have that discussion with your primary care doctor. Make sure that you've got a list of your medications and your allergies and your medical problems, and know where you're going to go. And just have that plan. And when you get there, sit back and relax and know that you're in the hands of trained nurses and trained doctors who are going to do everything that they need to do for you.
Thank you both for coming.
Thank you for having us.
For more information about emergency medicine and what you can do to prevent medical emergencies, visit the websites listed at the end of our show. And to view past physician-focused programs covering a variety of healthcare topics, visit our website at www.physicianfocus.org. I'm Dr. Bruce Karlin. Thank you for watching.
I'm Dr. Nathan MacDonald.
I'm Dr. Jeff Hopkins.
For many medical emergencies, time is critical and delay in treatment can lead to more serious consequences.
That's why we encourage you to learn some of the common warning signs and symptoms of medical emergencies that might require a visit to the emergency room.
If you or someone you're with has difficulty breathing, chest pain or pressure, sudden dizziness, difficulty speaking,
uncontrolled bleeding, persistent vomiting or diarrhea, sudden or severe pain, or is coughing or vomiting blood,
go to an emergency department. Specialists are available 24 hours a day, 7 days a week.
Remember, too, that the most important step in preparing for emergencies is to prevent them from happening, so put safety first.
And develop a plan to follow when emergencies do occur. Know your medications, medical conditions, and the name of your primary care physician.
For more information on warning signs and preventive steps for emergency medicine, visit emergencycareforyou.org.
I'm Dr. Dennis Dimitri. One of the most important medical decisions a person can make is choosing a primary care doctor, one who provides your overall care and coordinates care for serious or complex conditions. You should consider many factors when selecting a new physician, but there are three that I think should be at the top of the list. First, make sure you feel comfortable with your doctor, that you can develop the critical elements of trust and respect that make a physician-patient relationship work. Second, focus on communication. Does the doctor listen to your questions and concerns and respond with adequate answers? Third, decide what kind of relationship you want. Do Do you want the doctor to make decisions for you, or do you want to make a more active role with someone who will engage in shared decision-making? A good relationship with a physician can last a lifetime and offer confidence in the quality of your care. For more information, visit the Massachusetts Medical Society at massmed.org.